Hi, thanks for the opportunity to speak today. So I'm really pleased to be giving a clinical genetics perspective on direct-to-consumer genetic testing. And to start, I should probably say I've taken quite a kind of loose definition of direct-to-consumer genetic tests from this UK context, being some sort of test which you kind of hand money over to have, but some of them will have involved some sort of clinical sign-off. But I thought it might be useful to start by kind of reflecting on what people might expect going into a genetic test. And as a whole, the way we're taught about genetics in schools is often quite a clear-cut way. Popular discourses around genetics often suggest the idea of genetic testing as giving quite clear and profound answers. And companies often lean into that idea, I think, of empowerment in selling tests. So one phrase I found when I was looking through some websites and preparing this talk was, if you're considering genetic testing, don't wait. Reach out today to take that important first step towards clarity and control. Looking at some more company website quotations, it can offer peace of mind, get reassurance with our extensive test. And I think that probably is often a driver for some people in exploring direct-to-consumer genetic testing. And accordingly, if you don't get the reassurance you were hoping for, it can be that bit more distressing. We had some really helpful conversations about direct-to-consumer genetic tests with our local PPI group some years ago, and they came up with some really good points I think have been raised already, that it's much easier to raise concerns around a person's health than it is to allay them. There's sometimes a perception that a test that you've paid for must be better than one that would be provided by the NHS. And they also, I think, made the important point that a lot of people are probably trying to reduce the burden on the NHS and you take responsibility for their health via accessing such tests. So with that in mind, I wanted to talk a bit about the concerns that some clinical geneticists might have about these tests. And this does come with caveats. There's a huge variety of these sorts of tests. Some will be much better than others. In fairness, I think companies often do include various of the issues that I'm going to outline in their disclaimers and their reports, but that said, they often still kind of seem to land as a surprise to people reacting to the results of these tests. And in fairness, I should probably also say that clinical genetics probably doesn't see the cases where things have gone smoothly, it's been helpful, so of course that might colour my view. But the first issue I wanted to talk about is one of false reassurance, and that's because colloquially, genetic tests are often kind of talked about as if they're one thing, but there's very different technologies underlying various tests. And for example, a test to look at the BRCA genes, where certain variants link with a higher chance of developing breast and ovarian cancer, could vary from a test that looks at the sequence of the gene from start to finish, trying to look at the complete picture to see any variants that might raise a person's chance of having breast ovarian cancer. It could also encompass a test which looks at little hotspots in the gene where there are known to be kind of common variants which increase the chance of breast and ovarian cancer, and at that specific point checks to see if that variant is there or not. And you'll appreciate, one has potential to miss quite a lot of the picture. So to give a sort of real life example, a direct-to-consumer BRCA test that was recently available that checked for 44 variants would miss most people with a cancer predisposing BRCA variant. And it varied a bit by ancestry. So people with European or African American ancestry would pick up about 30 to 40% of people with a cancer predisposing BRCA variant. For people with East Asian or South Asian ancestry, the test performed less well. And the worry from a clinical genetics perspective would be, someone with a concerning family history of breast and ovarian cancer, having a test of the sort of type that just looked at little hotspots, then being reassured by the finding of not being found to have a BRCA variant, and not then turning to the NHS to access the kind of fuller picture test for which they might be eligible. The next issue I wanted to talk about was sort of the opposite end of the spectrum, and I wanted to just reflect on kind of two ways in which these tests can sometimes generate false positives. So the technology that underlies some of the tests involving SNP chips, which sort of look at precise points of your code for whether the variant's there or not, they're very good at saying whether a common variant is there or not. But for very rare variants, there's actually quite a high false discovery rate. and quite often they're more likely to be wrong than right. So based on UK Biobank data, 95% of the cancer predisposing BRCA variants that they found via that technology, when they looked via a different technology at the person's genetic code at that point, it wasn't actually there. So only 1 in 20 were actually there when you looked in the code. In fairness to direct-to-consumer genetic testing companies that use that platform, I think often they are aware of that and they wouldn't report on variants of that type. But some have the option to kind of download your raw data from the test. So, for example, you might have an ancestry test, kind of tracking your family history, download the raw data from that. And then there's options to sort of feed it through third-party interpretation software that aims to make comments on your health. And that kind of thing can see these artifacts, not recognise them as artifacts, and sort of present them as a serious health risk that they found in the genetic code. And I think in clinical genetics, there have been situations of people who've got to the point of, having appointments to discuss risk-reducing surgery around this sort of thing. And then someone said, we should check in an accredited lab that it's actually there, and it hasn't been. The next false positive issue I wanted to talk about is one that's probably going to show up my ignorance of statistics, but I think it's basically, I think the concept is if you do a test that's right 99% of the time, but if you're looking for an outcome that's there much less than 1% of the time, actually quite a lot of the time when the test says there's an issue, there won't be. And I've used a fairly kind of well understood example of non-invasive prenatal testing to illustrate this, where in pregnancy you take a sample of the mother's blood and from that look at the genetics of the fetus. And in a sort of general population chance context, when you're screening for common trisomies like Down syndrome, Edwards syndrome, Patau syndrome, if such a test says that the fetus isn't affected by one of those conditions, it probably is correct. But the positive predictive value is not 100%. So if it indicates there's a high chance the pregnancy is affected by Down syndrome, it's probably about an 82% chance that's correct. If it suggests Edwards syndrome, it's about 37%. So it's more likely than not that the pregnancy wouldn't be affected by Edwards syndrome. And for Patau syndrome, it's about 50-50. The positive predictive value will be lower for rarer conditions, and some tests, like for example, exploring sex chromosome aneuploidies or various microdeletions, will have lower positive predictive values than this. In 2022, the US Food and Drug Administration warned a kind of range from 2 to 30% for microdeletions, depending on the condition. They did also note that people had ended pregnancies on the basis of such screening results without having confirmatory testing. And another concern I just wanted to highlight is often these tests aren't designed to be sensitive to the clinical context, and the predictive meaning of a disease-causing variant, I think we're increasingly learning, is often quite reduced when found outside the context of the family history of the relevant disease. So it doesn't mean that it doesn't increase the risk, but the numbers we would quote that we've ascertained in families where lots of people have been affected by a condition might not quite match the situation where it's found in somebody who previously we would have said was a population chance of a condition. And because of this, there's policy which is developed around this. So this joint position statement, which was updated last year, has set out various recommendations around direct-to-consumer genetic testing that's sort of attentive to that. So one is that people shouldn't be taking at face value or attempting to interpret reports from non-accredited laboratories or third-party interpretation services, and that's kind of for that issue that they are quite often going to be wrong. This other one, which I think speaks more to the worry of false reassurance, is saying, again, as a healthcare system, we shouldn't let ourselves necessarily be reassured by a direct-to-consumer genetic testing result. And if you think somebody you would normally want to refer into clinical genetics, you should do that anyway, regardless of what a direct-to-consumer genetic test says. And I think the upshot of that is actually the great majority of direct-to-consumer genetic tests really don't result in a referral to clinical genetics. And lots of those referrals will be rejected or will be dealt with by advice by letter rather than actually resulting in a clinic appointment. But that said, I think for some genetic services, picking results from direct-to-consumer genetic testing does represent quite a significant portion of their workload. In Wessex, where I'm based, I think it's probably the prenatal setting where we see the biggest kind of impact from this in terms of clinical time. And I think that's got a bit to do with the consent process for direct-to-consumer genetic testing, because often when these patients are seen in clinical genetics, it's in the context of trying to sort of retrospectively give the information and context around unexpected results that ideally should have been given before the test happened. And there's probably a real kind of tension for companies in selling their test and justifying why people should part with their money to have it, and informing consumers of the limitations. And I think the upshot of that is sometimes stuff is framed in a way that makes it difficult for people to really attend to the risk. Like, for example, a phrase I saw is, no test is perfect, and of course there's a chance of false positives and false negatives. I think key information is also often hidden in the small print, and I think Annika showed me this example of a really nice experiment that, that illustrated the lack of reading of the small print. Because somebody set up a Wi-Fi hotspot, and you had to click to kind of sign on to it, and that involved accepting terms and conditions where you gave your eldest child to the Wi-Fi provider. And a lot of people thought that was a good deal, or didn't read the terms and conditions. But actually, there's loads to think about when having genetic testing. Is it the right time in your life to have the test? Is it the right test for your clinical question? What is the test actually looking at? And what might it be like to have one of those outcomes? And this QR code links to a BBC story that was written by a journalist about her personal experience of having a non-invasive prenatal test that indicated her fetus had a high chance of being affected by Turner syndrome. And I thought she wrote really brilliantly about the kind of human impact on that and how difficult that had been to navigate. And I think it showed various of the issues really well. Of course, this will have some resource implications, because when we're acting to people with direct-to-consumer genetic tests, that necessarily pushes other people further back in the queue. And because this, I guess with the clinical background, I focus mainly on the clinical side of this, but people turn to genetic tests for all sorts of reasons, like exploring ancestry, tracing relatives, and exploring wellness or traits. But I guess in common with that, these are involving data with lifelong relevance to you and to your biological relatives, and with potential to reveal potentially unexpected and sometimes unsettling information. And I'd say also it sometimes seems quite opaque to me how the results are arrived at, like how they get from the DNA you sent them to some sort of assertion about your traits, for example. So the key points I wanted to make, I guess, are that often people have quite high expectations of genetic testing, and I think unless this is sort of responded to, it kind of creates a risk of people over-interpreting the information from many of these tests. Where they do interact with clinical genetics, it's often been in situations where the pre-test counselling clearly hasn't worked for whatever reason, and often post-test support has been lacking too, and a company's just said, signposted someone to do the test rather than taking that responsibility for the results that they provided. So just to enter some reflections on what might be evidence of higher quality direct-to-consumer genetic test. I think it should be a given that the technical aspects are robust, so it does need to be a properly accredited lab. But also genetic testing should be more than just sort of feeding DNA through a very generic pipeline and not having awareness of the clinical context in creating the results. And I think it's a really important question where genetic counselling features in the pathway. Is it an integral part of the whole process, and does that continue kind of before to beyond the test? Or is it something where, if you pay £300 after this result, we'll actually get someone who might speak to you about it? And I think also a question of how statistics are chosen. Are they chosen to really inform the prospective consumer? So are they kind of meaningful ones like positive predictive value, for example, or are they ones which make the test look good? So I just want to say thank you very much to Helena, who helped me with that. Thank you.